Chapter 22 pertains to the peripheral vascular system. The components of the peripheral vascular system, the main components are arteries, veins, arterioles, venules, capillaries, and of course the lymph system as well, the capillaries, lymph nodes. Arteries carry oxygenated, nutrient-rich blood from the heart to the capillary. The capillary is where the action actually occurs, where the gas exchange, where nutrient exchange is going to occur, but the arteries have the job of carrying that blood to the capillaries. And they're doing it at a high pressure. Think the systolic pressures, and the minimum that they would pressure that they would have would be the diastolic pressure. So they're going to be at high pressure. And if you think about, if you've ever done any home improvements, you know that the pipes that you use for high pressure, like say for your water, running water or something like that, have to be much thicker, and the joints in those pipes have to be much tighter, and there's less, they have to be designed for high pressure as opposed to pipes that you're using for drainage, drain water. And the walls of the arteries have to be thicker as well. There are elastic fibers in these arterial walls, and their purpose is to allow for some amount of stretching. And that part of that is in order to regulate the blood pressure itself, because blood volume is going to be going up and down, and the needs of the body are going to be changing, and so you have to have a way of regulating the blood pressure, and one way of doing that is by increasing or decreasing the size of the arteries, and so the elastic fibers allow for that. Arterial pulses, you we'll only be able to feel those in certain places, as we'll see, but an arterial pulse actually goes throughout the arterial system. We're only able to feel it in a few places, but it's going throughout the arterial system, and it's a surge that is created by heart contraction. And the places where we're going to be able to feel it are where the artery is close to the surface and passes over a bone. So there are a few more pulses besides this, but these are the ones we're going to be talking about in this chapter. The brachial pulse, and that one you'll feel in the fold of your elbow. It's right between the two muscles there in your antecubital fold. And then the brachial artery divides into the radial, which is on the thumb side of the wrist, and the ulnar, which is on the opposite side of the wrist. Both of those arteries supply the hand, and the design is such that theoretically, if one of those is cut off, the other would be able to supply the hand with the blood it needs. We'll see, a little later we'll talk about the Allen test, where we'll be checking to see if that is indeed the case with a patient. But the radial pulse is normally much stronger. The ulnar pulse sometimes is hard to find, and normally the radial pulse is much stronger. The femoral pulse is in the groin area. It's actually the strongest pulse in the body, and when you there's no other pulse at all, you may still be able to find on somebody that's actively dying and almost dead, you may still be able to get a femoral pulse. And it's in the groin area. The popliteal pulse is behind the knee. It corresponds to the brachial pulse, as if think of the bend of the knee, and it's also lays between the muscles there. Then the dorsalis pedis is going to be on the top, the upper or dorsal aspect of the foot, and the posterior tibial is on the inner aspect of the ankle. And those two correspond to the radial and the ulnar in the sense that if one of them is cut off, the other one is supplying the foot. And so typically we'll have you check in the lab for both of those on your partner, but typically so long as you find one or the other of them, or why then you're happy that your patient has some degree of circulation to the foot. Now, veins carry deoxygenated blood from the capillary bed back to the heart. So, and then veins are a low pressure system. The pressure in the vein is close to zero, actually. And so that brings up the question of how does the blood move at all in the venous system. And the main force that moves the blood along is going to be muscular contractions, like as you move, various muscles are going to contract and relax, and that will move the blood in the vein forward. And then there are one-way valves that prevent the blood from flowing back. In some conditions, such as varicose veins, that's not the case. Those valves aren't working, or they may be compromised, or they may just not be working at all. The veins are larger in diameter than the arteries, but their walls are not that thick. They can expand as needed to and the venous system normally contains 70% of blood. Particularly if you think about, you haven't learned about starting IVs yet, but maybe you have seen a nurse looking for a vein. They typically will put a tourniquet on, or if you're looking to draw blood, you'll put a tourniquet on, and that vein immediately, the veins on below the tourniquet will immediately bulge out. And so you're taking advantage of that. You're blocking the flow of the blood, and you're blocking the flow of the blood, and so the blood is going to accumulate, stretch that vein, and make it easier for you to stick it. There are three types of veins. Deep veins, which you probably will not ever see unless you go into the operating room. Superficial veins are the ones that you typically see, and perforator veins or communicator veins are the ones that go between those two. So some of the most important veins in the legs, the femoral and popliteal veins, those are the deep veins. And then the great and small saphenous veins are superficial. You'll particularly see those in the case of somebody that has varicose veins. Then you'll be likely to see those too. Then in the arms, there's the cephalic and basilic. That's a spelling error there. It should be basilic, not basilica. Those are superficial veins that we use a lot when we're doing blood draws, for example. And then the brachial vein is an example of a deep vein. capillaries are where, as we said, that's where the actual gas exchange, nutrient exchange, and all these things occur. They're small vessels that connect an arteriole and a venule. So blood is flowing out of the arteriole into the capillary, and then the exchange takes place and it comes back in the venule. And remember, we've got a semi-permeable membrane here. So due to the hydrostatic pressure, that's just the pressure from the artery, the fluid pressure itself, that pushes fluid out. But osmotic pressure is going to pull some fluid back in, and the fluid that doesn't get pulled back in that way, the lymph system is going to take care of that, assuming that the lymph system is working properly. If there's something that causes your osmotic pressure to decrease, why then you're going to end up having edema. What could cause osmotic pressure to decrease? Well, one of the main things is a problem with low protein. Albumin is one of the main things that contributes to osmotic pressure. There are various other things too, but albumin, if albumin is low because of malnutrition, because of liver disease, then you're going to have decreased osmotic pressure and you'll have edema as a result. If your lymph system is not functioning, then you'll have massive amounts of edema, what we call lymphedema. The lymphatic system is going, as we said, it takes care of extra fluid that's in the interstitial space after the osmotic pressure has pulled some of that fluid back. And so it also removes proteins, particularly if you've had an infection. And we know that when you have an infection, there's a battle between the infecting agent and your white blood cells and various macrophages, all sorts of debris is left after this, and that has to be cleaned up. And so the lymph system is going to drain quite a bit of that fluid as well. And the lymph system consists of lymphatic capillaries, vessels, and lymph nodes. The lymph nodes are filters that filter out some of those debris, some of that debris. And so if you've had an infection, it's not at all uncommon for a lymph node to be enlarged as a result. Sometimes they can get quite large, like 1 or 2 centimeters, and you can panic. One time I had this lump in my groin area, and I was, oh, what's happening? Could it be cancer? Is it a tumor? I was pretty young at the time, and so I panicked, and it turned out to just be a lymph node that was inflamed. It eventually went away, nothing happened, and everything was fine. But it got so swollen that this lump got so swollen that I was feeling numb in that leg. So sometimes people can come to you with symptoms and they're panicking, and it turns out to be nothing. And then other times we have things that seem like nothing and they turn out to be serious. Anyway, getting back on topic. The upper right side of the body is going to drain into the right lymphatic duct. But the other 3/4 of the body, all of the left side and the right lower side, is going to drain into the thoracic duct. Lymph nodes can either be circular or oval, and they're grouped together. They form chains, what we call, and you'll learn about various chains as we go along, various lymph node chains. Usually they're very small, but they can be up to 1 to 2 centimeters in diameter. And usually you won't feel them at all. You palpate for them and you don't feel them at all. They should not be hard. We call those shoddy lymph nodes. If you do feel an enlarged one, it should be fairly soft. Many of them are located near major joints, so that's a good place. I mean, that's where a lot of them are found. And they can either be superficial, the chains can either be superficial or deep. The chains we'll be talking about in this chapter are the axillary, epitrochlear, and then there's two inguinal chains, the horizontal and vertical inguinal chains. So, starting with history of present concern, what kind of circulation problems could a patient be presenting with? Well, maybe a color or texture, temperature change in the skin. Maybe even a wound that turns out to be a vascular wound. We'll talk about vascular wounds a little later. Or maybe a problem with cramping or other types of pain in the legs. Pain when walking, a feeling of heaviness in the legs, or edema, particularly in the lower extremities, but you could also have edema in the upper extremities. And likewise, you could present with maybe numbness and tingling of the fingers, or say the toes. You could present with a problem of bulging or contorted leg veins, or maybe sores or wounds. A swollen gland, like I went in with many years ago. A swollen gland that you think, oh, what's this? Is it dangerous? Am I going to die? You know. Or in the case of males, sometimes a vascular problem can manifest as a change in their usual pattern of sexual activity. You think, why on earth? Well, the penis is peripheral circulation, so if you have a problem with circulation, usually the peripheral circulation is going to be the first to be sacrificed: toes, fingers, and the penis. So you may have trouble getting an erection or maintaining an erection, and that can be one of the first manifestations for sure of diabetes, or of vascular insufficiency for some other reason too. Now, you're going to be asking about personal history. You'd ask about any previous problems with clots, any problems with ulcers, coldness, circulatory problems either in arms or legs, any surgery done on the heart or vessels. And then as far as family history, a family history of deep vein thrombosis, diabetes, hypertension, chronic heart disease, intermittent claudication. What is intermittent claudication? That's when you have blockage of an artery, but it comes and goes. It's not a continuous blockage. And the typical scenario is that somebody walks a couple blocks and then they get sharp pains in their legs and they have to stop. They rest for a while, the pains go away, they walk some more and the pain returns. And what's happening is that artery gets constricted, unblocked, and they have the pain, and then when they rest, why then it relaxes and the problem is relieved a little bit. Any family history of elevated cholesterol or triglycerides would also be of concern. What are the risk factors for peripheral arterial disease? And most of these are also for peripheral venous disease as well. smoking, diabetes, obesity, hypertension, high cholesterol, a family history of it, age, increasing age, homocysteine levels. And that's one of the lab tests we do. It's a protein that's found in the body if the level is elevated, and it can be tested in the lab. And then African Americans are at risk for this disease. So, turning to the objective assessment, this is some of the equipment you're going to want. A tape measure, stethoscope, a Doppler device. The Doppler can detect pulses when you can't feel one. So that's why we do that. And sometimes beyond your assessment, sometimes the physician will order what's called Doppler studies, flow studies, where a technician does studies on the arteries and veins and detect flow. Then a tourniquet, gauze or tissue, waterproof pen, and blood pressure cuff. So start with observing arm size and venous pattern. Are the veins tortuous? Is there a difference in size between the two arms? Does there appear to be any edema? And then look at the color of the hands and the arms. In the textbook there's some illustrations of some dramatic color changes at the end of the chapter. Then palpate fingers, hands, and arms for temperature. And when you palpate for temperature, you're going to use the dorsal aspect of your hand. Assess for capillary refill. You just pinch the nail bed and see if the pink, if it should whiten immediately, but then it pinks up again within 2 seconds. So the way I do it is I say to myself, capillary refill. And if it's pinked up before I finish saying capillary refill, then I know that it's done it within 2 seconds. If say they have nail polish or artificial nails, then you can go a little bit above the nail bed or just below the nail bed and do it there. Then palpate radial and ulnar pulses. If you can't palpate them, one option is to get a Doppler. If you don't palpate either one, why then you want to know where is the last. Maybe it's a person that actually does have a problem with circulation and you can't find a radial or an ulnar pulse. Well, go up a level. How about a brachial? Do they have a brachial pulse? Sometimes on tests I'll ask questions, what do you do if you can't palpate a pulse? And if it's an emergency assessment, like if you've got somebody that's unresponsive, you're not sure if they have a pulse at all, if their heart's beating, why then that's one thing. You would try the carotid pulse in your CPR algorithm. If you don't palpate a pulse, then you start CPR. That's the emergency situation. But if you're not in an emergency situation, you know the person is alive, you know they're responsive, why then if you don't get a pulse in a distal area, and maybe you try it with palpating it, there's a couple of other things you could do next. One thing to do is find where is the last easily palpated pulse. So going upward from the radial would be the brachial pulse if you can't find that, why try the brachial pulse. Another thing is do other tests to see if they seem to be having a problem with circulation. Like, do they have, is their movement, circulation, and color to the hands intact? If they don't have any other symptoms relating to poor circulation, why, maybe they are actually being provided, maybe they don't have a radial pulse for some reason, but do they have the ulnar pulse? As we know that the ulnar pulse can supply the blood, provide blood supply if the radial, so you'd be a little suspicious, well, maybe my technique is not that good, maybe I'm not in the right place, or maybe I'm not palpating correctly, and that radial pulse is truly there. But it could be missing, but then we know they're getting circulation some way. Maybe they actually have an ulnar pulse, so you could palpate for that, or if you and then you can also look with it using the Doppler, of course, too. But if you're finding something that's way out of line with your other findings, why, probably check your technique, or maybe check and see if somebody else can find it or something like that. Because now, if the person has other signs of circulatory problem, then it's quite possible that they don't have that pulse that you're looking for. Okay, palpate epitrochlear lymph nodes, and you just kind of reach up above the elbow. Like if you have your hand, you kind of reach up to the elbow and up a little bit up above that and feel there in order to palpate the epitrochlear nodes. And now we get to doing the Allen test. And the way the Allen test works is you find the radial and the ulnar arteries. You have to find those two pulse points, and then you press hard on there and ask the person to move, to squeeze the hand, squeeze and open the hand several times. And if you're actually pushing hard enough and including it, the hand is going to turn very white. It will be a pallor. So then if you're testing to see if the radial circulation is adequate, you would release the radial one and see if it pinks up. But if you're testing the ulnar, then you would release the ulnar one. Usually why we're doing this is we're testing to see if the ulnar circulation is adequate, because we want to do a radial stick. So usually you would release the ulnar and see if the hand pinks up that way. Because usually the reason we're doing it is we plan to do a radial stick, either to put in an arterial line or to draw an arterial blood gas. So we want to make sure that if we mess up that artery, why the ulnar circulation is adequate to perfuse the hand. Now, after you've done that, observe skin color from toes to the groin, and observe the distribution of hair on the legs. As we'll see, hair loss is particularly happens when you have arterial problems, when you're arterial insufficiency of the legs. Inspect any sores or lesions that the person may have and document and describe those. In some institutions you may be asked to take a photo if you're admitting a patient, or maybe they will take photos periodically to assess the wound healing as well. Then observe for edema, and you can observe for it and also palpate for it. And we'll talk a little bit later, you can also grade the edema. If you find edema, you're going to say grade it and say whether it's pitting or not. Palpate for temperature, again using the dorsal aspect of your hands, and palpate for the inguinal lymph nodes. And you cover the genital area and palpate up at just below the groin on the inner aspect of the thighs. Now, next you're going to palpate the femoral pulse, and you'll want to auscultate here to see if you hear a bruit. Then we'll also palpate the popliteal, which, remember, we're going to do that in the behind the knee, in that fold where the legs fold in that knee fold. Then dorsalis pedis, that'll be on the dorsal or top aspect of the foot, and posterior tibial, that'll be on the medial aspect of the ankles. I frequently see students trying to find it on the outer ankles, and you'll never find a posterior tibial there. Then inspect for varicose veins or possible thrombophlebitis. So what does that look like? Well, it depends on where it is. If it's a deep vein, you may not see anything. That's dangerous. If it's a superficial vein, you may see a red streak or an area of swelling. And if you do kind of tap on that area and see if it's tender, that would be suspicious for thrombophlebitis. Now, don't mess with it once you've determined that it's tender. Don't do anything further to try and tap or massage or anything like that, because theoretically you could break a clot loose and it could become an embolism, and you don't want to do that. You just want to stop and report this. Another thing we do that you may hear about is Holman's sign, where you dorsiflex the leg, and if they have pain, why then that's said to be indicating thrombophlebitis. And that's something you would report and have to check out, but it's not at all certain, because other things, you can have that Holman sign and not have thrombophlebitis, or you can have thrombophlebitis and not have Holman sign. So it's just something that you would want to, if you would want to stop your assessment. If you have anything suspicious of thrombophlebitis, you'd want to stop your assessment, report it, and get further tests ordered to rule out the phlebitis. Because for one thing, if you do other things with the legs, you wouldn't want to let the patient walk, for example, until they'd been evaluated. If you suspect phlebitis, you wouldn't want to let them walk. So you'd want to, kind of elevate that leg and just leave it alone until they could be evaluated for the phlebitis, because that is not the biggest emergency situation, but it is kind of an emergency situation, because there is the possibility of that phlebitis breaking loose and becoming an embolism, causing pulmonary embolism, stroke. Depending on where it goes, it could, do a lot of damage. Position change test for arterial insufficiency, and we'll see how that works in a minute here. And then also ankle brachial index. These last two are not part of the routine assessment. They're like if you were suspicious for arterial insufficiency, you would do these. So the position test is done, as I said, it's done in legs if the legs are, pulses in the legs are weak, or if you, for some other reason, you suspect arterial insufficiency. So you're going to take your two forearms, you'll support the ankles with one and the knees with the other, and you're going to raise the legs 12 inches above the heart and keep them there for a minute or so and ask the patient to move their feet and ankles. And after a minute, then the venous blood will be drained, and they should you'll look at the color. Depending on the patient, it can either be pink and normal, or maybe it's slightly pale, but you wouldn't expect to see really extreme pallor, marked pallor, because you're not occluding the arteries. But if there was arterial insufficiency, it might be extreme pallor there. That would be something that, okay, this does look like arterial insufficiency. Then anyway, then the next step is to sit the patient up, and you note how long it takes for those feet to return to the color they were at the beginning. And if you have a dark-skinned client, why, you're going to be looking at the pads of the feet, because you wouldn't be able to see it on the dorsal aspect necessarily. So if they return to their previous color in less than 10 seconds, then it looks good. That's a normal result. But if they're delayed in returning, that would be suspicious for arterial insufficiency again. And then you would also see if there's a delay in refilling superficial veins. Well, sometimes, some people, you'll see veins on the foot. You'll see superficial veins. Other people you don't. So if you didn't see them to begin with, why then you won't see them refill. But if you saw them to begin with, and then they would empty out when you had the foot up for a minute, so when they should refill within less than 15 seconds when you lower the legs. Now, the ankle brachial index is just the relationship between the blood pressure that you check in the arms, the brachial artery pressure, the systolic, and the systolic blood pressure that you get at the ankles. You can take blood pressures anywhere. I mean, anywhere there's an artery, you can theoretically take a blood pressure. It's going to be quite hard to do with your regular stethoscope, but with a Doppler you can do it. The only thing is, with the Doppler you're only going to get the systolic. You won't get your diastolic with a Doppler. So, and that, for this purpose, that's fine. All we need is the systolic. So, first thing, you're going to let the person rest supine for 5 minutes or more. Then you'll check systolic blood pressure in both arms using a Doppler and record the higher reading. Like if it's in the right arm, higher in the right arm, or the left arm, whichever one it's higher in, record that reading. That's going to be your arm reference there. Then you'll check in both ankles, and you can check the dorsalis pedis and the posterior tibial and see which one is higher of those two. So let's say you got 110 in the arm, that was the highest one, and you got 120 was the highest. Say you got 120 in the dorsalis pedis and 110 in the posterior tibial. Well, you're going to take the higher one, say that was the right ankle. And then on the left you got 110 and 110. Well, okay, for the left the ratio is just 110 to 110, that's 1. For the right it's 120 to 110, so you would divide 120 by 110, and it's going to be a little over 1. We'll say 1.1. And then 1.1 would be a normal value, so you'd have a normal value on both sides there. What should it be? Well, anywhere from 0.9 to 1.3 would be normal. If it's over 1.3, over 1.3, then that suggests that it's falsely elevated because the arteries in the ankles are rigid, abnormally rigid. And if it's less than 0.9, why that also is abnormal. That would suggest either if it's say 0.5 to 0.9, that would be moderate, but 0.5 or lower would be severe. And I believe, I can't remember the number, I think it's 0.3 or less, the limb is probably going to be amputated soon. Oh, 0 to 0.4 is that suspicious for that they're going to probably be gangrenous and have to have their limb amputated soon. Then the manual compression test. This is done if you see varicose veins, or if they say they have a history of varicose veins. So you ask them to stand, and then you would firmly compress the lower portion of the vein with your hand, and then taking your other hand, you feel about 6 to 8 inches higher on that vein and see if there's any pulsation. And you shouldn't have pulsation. If you do have pulsation, that would indicate that the veins are incompetent. The valves are incompetent. Then the Trendelenburg test, also for varicose veins. You'd have the client lay supine, and you elevate their leg 90 degrees and keep it there for 15 seconds. Then you put on a tourniquet, not so tight that you occlude the arterial pulses. You'd have to be have a regular tourniquet. You're not going to be doing that, so no worries. But we don't want to just completely occlude the arterial pulses. We just want to, and then once that tourniquet is on and you've had the leg up for the 15 seconds, you help the client to stand up, and you observe the vein proximal to the tourniquet for filling from above. That would be an abnormal finding if it fills from above. It can't fill from below because you've got it blocked off. So, you know, the vein that the proximal area, the vein above where you have the tourniquet, should not fill from above. Then you remove the tourniquet, and you should see some filling in about 30 seconds, but you shouldn't see a rapid filling that's coming from above. Pulse grades. When we were in the chapter on the heart and central vessels, we learned a 3-point grading system for the carotid pulse, 0 to 3. And here we've got a 4-point grading system, which is a little different, but it's 0 would be absent, and then 1+ would be weak and easy to obliterate. Most people are going to be 2. Could be could be 3, and that's still normal. But 4 would be abnormal, abnormally bounding and unable to obliterate. Then, of course, the edema scale. This is not found in the textbook, but I'm giving it to you here. So just think the grades of edema are going to be, if you double that, that's how many millimeters of depression you'll see. Pitting means that the edema stays, the depression stays. So it's not always, you may have edema that rapidly, that the depression fairly rapidly comes back, or the depression may come back right away, and then that would not be pitting, but it's still edema. or you may have pitting edema, and then these are approximate amounts of time. If you did have pitting edema, these are about approximate amounts of time that it would stay depressed. So one of the problems, if you detect that there's some vascular insufficiency, then you have to decide, well, does this look like venous insufficiency or arterial insufficiency? Well, some of the characteristics of arterial insufficiency, the pain is probably going to be sharper than in venous, although venous can be sharp pain, but sometimes you'll have intermittent pain. Remember, we talked about intermittent claudication, where the person complains about pain when they walk or move their legs or exercise their legs, and then it goes away when they stop. But it can be sharp, unrelenting pain as well. And then if you elevate the foot, does it become very pale? That would be characteristic of arterial. Then is it a cool, dry, and shiny skin? Cool to touch, dry and shiny skin, with hair loss over the toes, over the dorsal aspect of the foot, sometimes even over the ankle. And then hard, thick, rigid nails. These are all pointing to arterial insufficiency. Venous insufficiency, the pain is usually dull, aching. It can be cramping, described as cramping. There may be areas of pigmentation, especially around the malleolus, the medial and lateral ones. Thick, tough skin, reddish blue color, and dermatitis changes associated with it. Then ulcers, if they have a sore, what does it look like? First, in arterial ulcers are characteristically on the tips of the toes, in the webs of the toes, the heel, the pressure areas. They're usually very painful, and the wound is usually deep, circular in shape, and the base of the ulcer can be pale black to dry and gangrene. And usually there's no edema, but there might be if they keep their leg dependent all the time. Venous ulcers typically occur in the medial malleolus or anterior tibial area. Pain varies from minimum to severe. Shallow in depth with an irregular border. And then the granulation tissue could be beefy red or yellow fibrinous, and it's frequent to have leg edema. So some of the diagnoses, a health promotion one might be readiness for enhanced circulation to the extremities. Somebody that comes and knows they have bad circulation and, well, what can I do to improve my circulation? Risk diagnoses, risk for infection related to circulatory impairment, or risk for injury related to altered sensation. Why do we have pain? It's a protective mechanism. So if you have neuropathy, as in the case of a diabetic, or many other conditions can cause neuropathy, but you have neuropathy, why then you're not going to protect that foot, and you're not going to be aware of injuries, and by the time you become aware of the injury, why it can be too late, and the injury can have progressed maybe to the point where you're going to lose a toe or a foot or even a whole leg. And then other actual nursing diagnoses, ineffective tissue perfusion related to, ineffective, that's wrong. Ineffective tissue perfusion related to impaired circulation, as evidenced by non-healing wound. Then acute pain related to arterial insufficiency, as evidenced by patient report. Collaborative problems and referrals. Risk of complications for DVT. Remember, if you see evidence of a DVT, you're going to stop your assessment and report it to a provider. And you don't stop your whole assessment. You would stop your assessment of that extremity. You might continue to do your assessment of the rest of their body, but you're not going to make them move. You're going to elevate that limb, try and keep it still, keep them in bed, and ask for orders for, say, some Doppler studies to rule out DVT. Risk of complications for peripheral vascular insufficiency, and that could be either arterial or venous. Risk of complications for gangrene. Gangrene is life-threatening. It's not that the patient is going to die in the next few hours necessarily, but if the patient has gangrene, they probably have to have that limb removed, or they will eventually die. And then risk of complications for ischemic ulcer.